Good evening. Thank you so much for watching Healthline on PBS Fort Wayne. I'm your host, Mark Evans. A very important subject tonight since it is Colon Cancer Awareness Month. We're going to talk about colonoscopies, and people I know are watching going, oh man, oh boy. But you know, they're very, very important. And as time has gone on, they have made it a lot easier. And it's something that we're going to discuss tonight. We're going to talk about the preparation for it. We're going to talk about the procedure, more importantly, the importance of it, and how you can get some help if you actually need it. So our special guest tonight is Dr. Jeremy Wilson. He is a general surgeon. He's been on the show before. Nice to have you back.
Well, thanks for having me back.
And I hate to say it, but the last time, well, I shouldn't hate to say it, but it's truth. But the last time you were on, we had phone difficulties. It was no fault. There was something in the area, phone system was down or something. But the phones are working tonight, which is a very good thing. You see that phone number on the bottom of the screen. It's 866-969-2720, and we are taking your calls on this subject. And typically we get several calls on this particular subject, and it's good because it's a very candid show. We're going to tell you just the way it is, and this show is to inform you about very important things such as colonoscopies. So, Dr. Wilson, let's go ahead and get started. Do you have any stats off the top of your head about colonoscopies and the prevention of colon cancer?
Well, you know, recently it's come out over the past several years that with the advent of widespread use of colonoscopy, incidence of colon cancer has gone down about 1% per year. But what we're seeing and what's a little troublesome is that risk reduction is more in the older population. And actually in the younger folks, we're seeing a 1 to 2% per year increase in colon cancers.
Okay. And it is something that well, let me phrase it this way. How long have colonoscopies themselves been around?
Oh, they've been around longer than probably you or I have been around.
Is that right?
But as far as a widespread use, I'd say probably we started seeing it most in the 70s and 80s, and then nowadays it's even more prevalent, available, and a lot of that has to do with some of those advances that have been made in preparation, procedure, sedation that we're going to talk about tonight.
Okay. Well, let's go ahead and discuss that. But my first question is, now with the and again, we're candid, but people call it the poop in the box.
Yes.
And also the test that you dip it into fecal matter.
Right.
What's that called?
The fecal occult blood test.
Oh, okay. Yeah.
Immunohistochemical test for that.
Well, I think it's important to stress that those don't necessarily cover all the aspects of a colonoscopy. So the question is, do I really need a colonoscopy when I take a stool test? Why is it done?
Colonoscopy is considered the gold standard as far as polyp detection and removal. And polyps are growths off the lining of the colon. Certain types of polyps, if left alone, do have potential to turn into a cancer. Those are called adenomatous polyps. Those stool-based tests that you describe do a fair job as far as detecting blood in the setting of the FIT test, or detecting blood and or what are called methylated DNA cells for the Cologuard or the in the box test. They don't pick up all polyps. They only pick up what they're designed to test for, and then they don't have the availability to remove a polyp if it's seen.
Right.
With those tests, if they do come back positive, they have to be followed up with a colonoscopy.
Well, why would a physician recommend those type of tests over a colonoscopy?
Convenience.
Okay.
Really, I mean, the not having to take time off of work, not having to do preparation as you would for a colonoscopy. It's one of those situations where if you can't do what's the best, it's acceptable to do one of those.
At least it's something.
As long as you're an appropriate candidate for those tests. There are some specific requirements that need to be met in order to have Cologuard. Not everyone's a candidate for it.
Okay, very good. We have a call coming in, and it looks like it's from Brian. And Brian wants to be off the air. And by the way, if you don't want your voice on the air, that's fine. But we'd love to hear from you one way or the other. But I'm going to read it off the teleprompter. Brian is asking, what are the risks of having colonoscopies? In fact, that was one of the questions I was going to ask. So I'll let you address that.
That's a very important question. I think that's one of the stumbling blocks that people have. in regards to getting their colonoscopy done are the risks. Colonoscopy complications happen 1% or less of the procedures. The main ones that we discuss are sedation risks, bleeding, especially post-polypectomy bleed. There's always potential for a missed lesion. And then the one everyone fears is perforation or puncture of the colon.
Mm-hmm. And those aren't very common.
Punctures happen well less than 1% of the time.
Okay.
The last statistic I saw was discussing all comers, not just people that have only a screening, but folks that even have some more advanced colonoscopic procedures. And those incidences are about 1 in 6,000 procedures. It doesn't stratify it down. It's going to be much, much less in the screening colonoscopy
and
population.
the punctures are mainly caused because of the weakness in maybe the rectal area or the intestine?
There are a few different ways that punctures could happen. One is, directly driving through the wall of the colon. That's something that's not seen all that often anymore. That was a little more prevalent back in the olden days.
Yeah, back in the 70s.
Back when you and I were young.
Okay.
Other things, removing polyp can weaken an area. If a polyp is large enough, it can make enough weakness that a perforation can happen just from blowing air into the colon, which is something that is required to see during a colonoscopy. There's also, in the process of advancing the scope through the colon, we see the end of the camera, but back upstream from where the end of the camera is, you can develop a twist or a loop in the colon, and if you push through that, it can cause a little tear in the lining.
But the optics on them, because they have cameras on them, as you mentioned, those have gotten so much better over the years.
Significantly better. The advances that we're seeing with our home televisions, with the 4K and the high def and all these other things are in the medical field as well, not just for colonoscopies, but for laparoscopes and those things. So we have, super high def, magnification views. There are different lighting sources that we use during colonoscopies that can help identify, is this a polyp? Is this just a normal fold? So kind of help in those determinations.
Right. Well, I want to talk about the prep and the actual procedure, but here's a little question for you. I remember when I had my colonoscopy, it was a big deal because I was over the age of 50.
Yes.
But now that is a younger set, right?
Right. And as we had talked about before, we're seeing more and more polyps and even cancers in folks younger than the age of 50. And so several years ago, recommendations actually lowered down to age 45 for average risk people to begin screening colonoscopy.
Well, and that's interesting too. Is it because as the age is getting younger, is that because of what we're eating? Maybe there's more alcoholic intake going on, or are all those true?
Right. Diet, certainly high fat, low fiber diet, alcohol, smoking, those are all risk factors for developing polyps and colon cancers.
A lot more people are doing those things.
Our diets have significantly changed, even since
that's
when I was young.
That's a whole other show. We'll have you back some other time to talk about that.
Very good.
But so 45 is a good time to get them started. How often should one have?
It depends. It depends on what's found during your colonoscopy. It depends on if you do have any of those risk factors. If there's family history of colon cancer and a first-degree relative, that's a significant increase in your colon cancer risk, and so you're more likely to have colonoscopy sooner. If you don't have polyps on your initial, most people would tell you 5 years for your next one. If you do have polyps, generally depends on how many polyps, how big they are. There are certain different types of polyps as well. Some carry a little higher risk than others. And so I usually tell patients, depending on the number, type, and size of polyp, anywhere from a 3 to 5 year range.
Okay.
If there are larger polyps that we have to take out in what's called a piecemeal resection, you take them out in pieces because you can't remove it all in one, it's too big for the instrument, then those people actually sometimes have to come back 3 months, 6 months, even a year.
I see.
To make sure that the entire polyp was removed.
I gotcha. All right, and I want to go ahead and remind our viewers tonight that we are live at this particular moment, and we're talking to a physician who's a general surgeon, Dr. Jeremy Wilson, and the subject, of course, is colonoscopies. It is Colonoscopy Awareness Month. So please give us a call, and I see a call coming in now, and while they're taking that, let me get on to the next one. Let's talk about preparation for a colonoscopy procedure.
Preparation, I think, is another probably the biggest stumbling block for people to get their colonoscopies done. You do have to have your colon completely cleaned out. I tell patients that the quality of the colonoscopy is directly proportional to the quality of the prep.
Okay.
Most preparations involve what's called a low residue diet for a few days before the actual main preparation, and basically try to avoid fresh fruits and vegetables, whole grains, things with a lot of roughage in them. And then the day before the procedure, most of the time it's clear liquids for that entire day beforehand. It doesn't have to be a colorless liquid, just has to be clear. We tell people if you can hold up the light and see through it, you can have it. Best to avoid certain colors such as red or purple because they can look like blood during a colonoscopy. The evening then before the colonoscopy involves taking laxatives, and there are various different protocols for that. It just depends on what you and your physician decide is going to be best for you based off of your other health issues.
Okay, very good. We have a call coming in, line number 5. Looks like Ray, he'd like to be offline. I'm going to read that for him. He says, I take blood thinners. How safe is it How safe is it to have a colonoscopy? Are there any other higher risks?
Blood thinner is a special consideration when it comes to colonoscopy. Depends on the type of blood thinner. Certain ones we hold for 2 days beforehand, others need to be held for a week beforehand. Being on a blood thinner and having it still in your system during a colonoscopy would increase bleeding risk, especially if biopsy or polypectomy is performed.
Okay.
So it just depends on the type of blood thinner. Typically we get with whoever is prescribing that for you and check with them and say, we need to hold this medication for 2 days, and we'll resume it as soon as we can afterwards.
And I think that whatever medications you're on, that the person doing that colonoscopy needs to know what you're on.
Absolutely. There are some medications, even not excluding the blood thinners, that should be held beforehand because they increase risk of injury to the kidney or electrolyte abnormalities. Other ones we definitely want you to take beforehand because they help protect the heart during the procedure. So yeah, it's important to go over with the physician that's performing the scope what medicines you're on, and make sure that you get in your preparation instructions the list of what you're supposed to take, what you're supposed to hold, how long you're supposed to hold it.
And I take an aspirin a day, prescribed, so that would be something I probably wouldn't want to take the day of my colonoscopy.
Most endoscopists are okay with the low dose, the 81 milligram aspirin. Typically the 375, the full strength aspirin, has enough what's called an antiplatelet effect that you'd probably want to hold that 5 to 7 days beforehand.
Oh, okay, 5 to 7. I didn't think it was going to be that long, but all right. We're going to talk about what you can expect during the procedure. We do have this call coming in from James. Can a digital colonoscopy replace the traditional colonoscopy? And will the digital colonoscopy give you a better result?
With digital colonoscopy, I'm assuming they're talking about the virtual colonoscopy or CT colonography. It has similar drawbacks and features to what we were describing for the Cologuard.
Right.
It does, however, still require the bowel prep beforehand. Basically, they run you through a CAT scanner, and then they do computer remodeling to make it look like you're flying through the colon.
Oh, I see.
It does pick up polyps. It can miss smaller polyps that may be caught on colonoscopy. And then the biggest disadvantage is that you can't remove a polyp with it.
Well, that's true. That's true.
And that's the point with doing the colonoscopies. Remove those polyps before they get a chance to turn into something else.
I don't know if we mentioned this or not, because we talked before the show. Sometimes we talk about before the show and what we talk about on the show. Sometimes I'm a little confused, but the instrument that you use, and we'll talk about that. Well, we'll talk about that procedure in a minute. But it has a camera on it. Plus, it has some surgical instruments that are attached to it. Is that correct?
There's what's called a working channel in the scope, and we can pass different things through the working channel. There are biopsy forceps that you can take biopsies with or remove smaller polyps. There are different sizes of what are called snares that we actually use. It's almost like a lasso. To snare a polyp off.
Okay, that's fascinating to me.
Yeah, different laser things to coagulate and things like that too, if you need to. If you have the capability at your facility.
I bet that's a very expensive piece of machinery.
I imagine you're right.
All right. Line 6, James, we did talk about that digital colonoscopy. I didn't realize that there was such a thing.
It's virtual colonoscopy, CT colonography. It is a legitimate strategy for colon cancer screening, similar to the immunohistochemical blood test or the Cologuard or the colonoscopy. it's kind of an in-between,
Okay.
but it still has that main drawback of inability to remove a polyp if it's seen.
Right, okay. Let's talk about what you can expect through the procedure. Now, I know that I was sedated,
Yes,
and I guess that is the common way to go.
very much so.
And is that conscious sedation?
It is technically called a conscious sedation. Before, when we were doing these, the majority of the time we would use a combination of two different medications. One, kind of a more sedative pain relief medication, than the other one kind of was a little sedation, but it would also give you a little short-term memory loss.
Oh.
More and more nowadays, we're having our anesthesia colleagues actually help us with colonoscopy. They give a medication called propofol. It works very quickly, but it also has the benefit of going away more quickly, so you don't have as much of that hangover effect as we used to have back when we were using some of those older medications, where people would say, you know, folks said I was awake and talking. I had no idea what I said. I don't remember anything until that next evening.
Now, is the patient aware enough if you have questions or you want them to roll over or something? Can they hear you? Can they respond to you?
Usually not with the sedations that we're using now.
Okay.
You know, if the advantage though, that medication does go away fairly quickly, and so that if we need somebody to move, anesthesia can turn that medicine off, and we can ask them to help us. Then they turn it back on, and it works then again pretty quickly to get them back to sleep.
Okay, gotcha. Well, so the procedure itself, you're going to have get the sedation, and I'm just kind of recalling from when I had my colonoscopy, and you're chatting with the doctor, and next thing you know, out like a light.
Yes.
And then it seems like I'm waking up in recovery. So it just goes by so quickly.
Right.
What's happening, that little dash there between beginning and the end?
Sure. Once patients are sedated, we usually will do, start out with just the regular digital exam, and also do an inspection to see if there's any sort of, hemorrhoid or fistula, abscess, or other perianal conditions. Then insert the scope. You advance the scope around the entirety of the colon up until where the small intestine hooks in. It's an area called the cecum. That's one of the quality measures for checking to make sure adequate colonoscopies are being done. You want to have greater than 95% of the time where you reach the cecum, get all the way in around the bowel. As we're going in, we're inspecting the lining of the colon. It's called the mucosa, and that's where these polyps start. That's where most of the colon cancers are coming from, are those polyps. Any polyps we see on the way in, we'll remove. We also spend a more thorough time than inspecting the entirety, the circumference of the colon on withdrawal, or removing of the scope. And that's another one of those quality measures that we want to say greater than 8 minutes withdrawal time. If you're withdrawing faster than that, significant chance you're missing polyps.
Okay. So after this is all over, when does that patient get the results?
It depends. If there are no polyps, no biopsies taken, we can tell them right away. We saw diverticulosis, which are little pockets that can develop in the colon. We saw hemorrhoids, we saw nothing. If there are biopsies or polyps removed, those have to go to pathology, and then we're kind of at the mercy of pathology to put them on slides, look at them underneath the microscopes to generate reports. But they're typically fairly good about that. We get results usually within a few days. Some of the more complex polyps that are removed, or if you biopsy something that you're fearful is a cancer, quite often a pathologist will want one of their colleagues to look at it as well before they put out their report and say, oh, this is a cancer. And so sometimes that can take a little bit longer to get that
double checking
back.
system. Okay. Now let's talk about when the patient does get the results. Of course, a negative result means?
If there are no other risk factors, then typically a recommendation is, as long as you're not having any new problems, repeat screening in 10 years.
In 10 years. And the positive result?
Again, it depends on the number, the type, the size of the polyps, but generally it's in a 3 to 5 year range.
Okay. Oh, really? So, well, that's not too bad. So I'm not going to be coming back next month necessarily.
No.
Okay.
That would be a very, very unusual circumstance. It does happen. With some of these larger polyps that we can't remove with traditional endoscopic techniques, there are specialists, what are called interventional gastroenterologists, that can do a procedure called endoscopic mucosal resection. They have really fancy endoscopes that can look underneath the lining, and they have different techniques that they can remove very large polyps and even early pre-invasive type cancers.
Well, and I know that there's probably not a long line at the colonoscopy window for people to have the procedure.
You might be surprised.
Really?
There are long, long lists of people that are waiting and just needing someone that can do that for them.
I see. So I know I had to be referred from my family physician when I had my colonoscopy, and it was just a routine test. I didn't have anything going on. We just wanted to, get in after I turned 50 and so forth. But do you have to be referred, or is there another way around that?
Depending on what healthcare system you use, some healthcare systems have what's called a colon clinic, or a number that you can call, and they'll ask you several questions. Is there family history? Are you on blood thinners? Do you have past history of polyp or cancer? And depending on your answers to that, sometimes they can just schedule you for the colonoscopy without having to be seen in the office first.
And I found too that most insurance companies, health insurance companies, say, yeah, bring it on. Get your colonoscopy. We're going to pay for it.
Yeah, screening tests are covered 100% by most insurance providers. And, from the insurance company's point of view, it's way cheaper to pay for a colonoscopy than it is to pay for a colon resection for colon cancer.
Absolutely.
It also is way, way better for the patient to have colonoscopy, have a polyp removed, rather than wait until we get symptoms, then we find it's a cancer.
Right. Any complications after a colonoscopy that somebody could expect?
Main ones, that we discuss: sedation, and we have our anesthesia providers there. People are hooked up to monitors, EKG, what's called a pulse oximetry monitor, which monitors oxygen levels in the blood, blood pressure monitors, those sorts of things. Any sort of anesthesia issues, the anesthesia people are right there to deal with, and they deal with it on the fly most of the time, be it give this medication or that medication. Another main one would be bleeding. If a polyp is removed, if a biopsy is performed, potential for bleeding afterwards. Most of those post-polypectomy or post-biopsy bleeds quit without any sort of intervention. It just may involve having to, be observed in the hospital for a bit and make sure we're not losing significant blood. If there is intervention required, quite often it can be another colonoscopy, and we, put a clip on a spot that was bleeding, or inject or cauterize or whatever we need to do. Okay. Very, very rarely would surgery be required, in the event of bleeding.
Okay.
And as we said before, the most dreaded complication, that being perforation or puncture.
Right.
It depends on the degree of perforation. You can have what's called a microscopic perforation, or a small puncture, where a little bit of air and other things escape outside of the colon. Treated very similar to diverticulitis, when those pockets can get infected. Antibiotics, bowel rest, and those usually resolve. Major perforations still would require surgery.
Okay. And we have about 2.5 minutes left, and we wanted to go over some of the most common fears, or some of the, what would you call it, myths.
Myths,
yeah.
yeah.
So what are some of those?
One of the main things we hear is this is going to hurt. And I think you hit it perfectly. Anymore nowadays with the sedation, people wake up and say, I didn't know you did anything. Are you sure you did something? Yeah. So there's not pain. Another thing we hear quite often, I'm too old for a colonoscopy. There is some incidence of thinning to the wall of the colon, maybe a slightly higher risk, but it's not prohibitive. When we're talking about colonoscopy, for bleeding or for symptoms, if we're talking about for screening colonoscopy, certain groups recommend stopping screening after age 75, unless, in speaking with your primary care, your family physician, it's thought that, you got a pretty long life ahead of you still, so let's keep going with that screening colonoscopy.
I would see no reason to not have one.
If it's a situation where somebody's, got a lot of other medical issues, they may say, this may not be the best for you right now. It's an individualized thing after that point, and yeah, people should definitely discuss it with their primary care provider.
Okay. Anything else as far as myths are concerned?
I think we've hit on.
Did we hit them all?
Well, not all of them, but we hit on quite a number of them.
The most important ones.
Yeah, I guess the biggest thing, the biggest point we want to get across is that colon cancer is out there. It's real. It can be prevented with colonoscopy, with removing a polyp rather than waiting until it becomes a cancer. Incidences are going down, especially in older folks, because older folks are a little more compliant with the screening guidelines. Younger folks are a little more resistant, let's say.
Well, in your experience, and we've got maybe 30 seconds left, are people fairly relieved, or are they happier once the procedure is done, and especially when they find nothing? What's the demeanor of that patient?
By far the vast majority of patients are so happy when it's over, and they say, I was worried about this procedure for nothing.
Yeah.
This really turned out to be, a minor inconvenience.
Well, I'll tell you, I fretted about it for weeks before I actually had mine, and I thought that was just absolutely ridiculous. I was in good hands with a good physician. The test went fine. They found nothing.
It's that fear of the unknown.
That's exactly right. I couldn't have said it better myself.
Hopefully we dispelled a little bit of those myths and made a little bit more known what was unknown.
And that's what this show is all about,
Yes,
Dr.
sir.
Wilson. Thank
Yes,
you.
sir.
Dr. Jeremy Wilson, General Surgeon, for joining us tonight on Healthline. It's always a pleasure to have you. And we thank you for watching. Thank you for your questions. And we'll see you next week on Tuesday for another Healthline episode. Until then, thanks for watching. Good night and good health.
PBS Fort Wayne was made possible in part by
Momentum, progress, innovation. Parkview Health knows standing still isn't an option. We must learn, grow, excel, and actively work to advance healthcare for our community and beyond. With technologies that improve access to care and teams of specialized providers, we are moving healthcare forward. Right here at Parkview Health.